I'm on the line. I can see you all, but I'm having trouble with my video.
Okay.
Can you hear me?
Yeah.
You can hear me though. I'm on the phone for that, but I'm also still trying to. For some reason, it's not coming up the video. But anyway, I'm here.
Brian, I'll figure it out. I'm glad you're here.
Yeah.
I see your name there now. Perfect. Okay, so welcome everyone. We're going to get started. We do have several questions that were sent in for tonight, but if you have more, you can either keep track of it for when we ask you or type it into the chat feature, and we'll look at those questions when we get to it. We do have a time limit. We're not going to let the questions go all night long, but we're going to get lots of learning happening. So if we could take a few minutes. I didn't ask any of the doctors to prepare anything, but if what we want to do is introduce them in case you haven't met them before. One of the great things about an in-person conference is you get to meet a lot of these people in person. So this is the closest we could do. So if you could just say who you are and where you work, and maybe a little bit about how you got connected with the Rett syndrome community, that would be great. So can we start with you, Dr. Carter, since you were the first one here? You've been ready for so long.
So there's a bit of background noise, so people who aren't talking could mute their
volume
themselves, or else we won't be able to hear. Thanks. So I'm Melissa Carter. I run the Rett Syndrome Clinic at CHIO in Ottawa, along with Dr. Sell. And prior to that, I was at Holland Bloorview, where I started the Rett Syndrome Clinic there, which is still going. And I got interested in Rett syndrome because I used to work with Peter Humphreys long time ago, and he sort of introduced me to it. And so when I moved to CHIO, I took over the clinic that he started in 2006. So yeah, that's me.
Thank you. Dr. Cassidy, you're next.
Great. Well, thank you for having me. I am a physiatrist, which is another way to say a doctor in physical medicine and rehabilitation, which lots of people have not so much familiarity with. So I work at an adult facility in London, Ontario, but I'm also cross-appointed to the Department of Pediatrics. So I have the opportunity to see our patients who are both on the pediatric side, but also on the adult side and long-term. So I became interested in this population when I was a resident, and I did my rotation, and I worked with Dr. Sue in her clinic at Thames Valley. And so when I started our transitional and lifelong care program for people with childhood onset disability, Dr. Sue came to me and she said, you have to take Rett syndrome patients into your program. And so we've been doing that ever since. And that's me.
Great, thank you. Dr. Sell, can you go next, and then we'll do Dr. Sue.
For sure. My name is Erick Sell. I am a neurologist at CHIO. I work with Dr. Carter. I also was inspired by Dr. Peter Humphreys' teachings, and was able to, as a junior staff, join his clinic. And now I have the pleasure of work with Dr. Carter, who kindly has accepted my inputs as neurologist in the clinic.
Excellent, thank you. Dr. Sue, we can hear you. Oh, we could hear you.
She's muted.
Okay, I'm here. Sorry, there's something weird about this connection, but so I am in London, and I first became interested in, I first heard of Rett syndrome from Peter, oh my gosh, Dr. McLeod, Patrick McLeod, and he was one of the first people, I think, in Canada who really became interested in Rett syndrome. And then I had my first young child, girl with Rett syndrome, and I think that her parents are on the line today. So she was really one who got me very interested in Rett syndrome, and eventually led to opening the Rett syndrome clinic in London. So that's me.
Great, thank you. And I know ORSA is appreciative of all of you for all of the time that you've spent to help us out and our families. So it's wonderful that you've all become interested. And I know a lot of people on the call know you personally, but that's helpful, especially for the areas that aren't covered by your clinics. I think they may have seen your name before and not really known who you were. So we're going to go through some of the prepared questions that were sent ahead of time. And if there are questions as we go, just send them in the chat. So the first question I have here has to do with diagnosis. And I'll see if Dr. Sue, maybe you can answer this one. How do you go about getting a loved one diagnosed with Rett syndrome? What about out of the province? Can a loved one be seen by a Rett clinic? So those could be two separate questions there. But just if there's someone on the line or someone we know who's looking for a diagnosis, what's the procedure?
Sure, thank you. So the diagnosis of Rett syndrome, typically, first of all, we think about the clinical symptoms, but actually Rett syndrome should be considered in any girl, especially, who has some developmental delay. And the actual testing, molecular testing, DNA testing is readily available. So it is a blood test that can be ordered and typically can be ordered by a pediatrician. You don't have to be seen in a Rett syndrome clinic to have that type of testing. So I don't know if that answers the question, but there are some girls who may have symptoms of Rett syndrome and who have had testing for the MECP2 gene. If they don't have a mutation found within that gene, then there are other genetic diagnoses that can mimic Rett syndrome. But generally having a what we call a pathogenic variant, a disease-causing change within the MECP2 gene is the way that we make the diagnosis. But of course, we also look for the clinical features of Rett syndrome. So I hope that answers the first question. The second one is about having, if you're out of province, if your child can be seen in a Rett syndrome clinic. And so we have the various clinics in Ontario, but there are clinics across Canada as well. And I think that it would certainly vary according to some of the different clinics. But we certainly can see children from outside of province to see them in our clinics. But generally, follow-up might be something that, again, might vary according to each clinic.
Yeah, thank you. Dr. Carter, can you, or Dr. Sell, I guess, for CHIO, maybe you could add to that in general, besides the diagnosis, if somebody has a diagnosis and they want to come from other parts of Canada, what's the procedure?
If it's a child under 18, depending on the province, you might have a Rett syndrome clinic closer to you. There's Rett syndrome clinics operating in Vancouver, Edmonton, Winnipeg, Montreal. So you should probably stay in your province if you can. Unfortunately, a lot of them do not see adults. We do at CHIO, so if you, no matter where you live, if you're an adult, then CHIO might be your only option, but we do, even more so now, we do virtual visits, so you don't necessarily have to come all the way to Ottawa to be seen.
Dr. Cassidy, while we're on the topic of adult clinics, how does it work with your clinic? You have more of a area that you cover, right?
Yeah, so my program is run out of London, Ontario. So most of the patients, maybe all of the patients that I follow currently who have Rett syndrome have come from our pediatric Rett syndrome clinic. So they've been referred to me for sort of ongoing monitoring and follow-up. So they just come to my clinic and hang out with me for the rest of forever, and I see them sort of as often as necessary or appropriate. But we are not closed to referrals from other places. So We have no sort of strictly defined catchment area, though I don't think we've ever had anyone come from out of province. But we do kind of serve a wide territory just based on the lack of services available elsewhere.
Okay, that's good to know because we have had questions about that, I think.
Mm-hmm.
Before we move on, Carrie Ann, I think you're on the line, and I know you had taken a lot of questions from young families looking for diagnosis input. Did we kind of cover what you thought the questions might be? She might not be listening right now. Okay, well, you can add to that if we've missed anything there. We're going to keep moving. The next section has to do with COVID-19. So there's been questions about any recommendations you might have about children going back to school. And along the same line, just generally symptoms. Are individuals with Rett syndrome any more at risk for contracting COVID-19 or developing more severe symptoms than your average person? So Dr. Sue, do you want to have a go at that?
Sure. So I think first of all, everyone is aware that the disease, the COVID in children tends to be milder than in adults, and indeed some, a fairly good number of children may potentially be asymptomatic carriers. But with the statistics that are coming out of the CDC, the Center for Disease Control in the States, and also our Canadian numbers, I think it's really important to put everything in perspective. There is no evidence at this time that children with Rett syndrome are particularly at any increased risk. There are certainly some comorbidities, so associated diseases that put someone at higher risk, but neurologic conditions in children, the bottom line right now is maybe there is a slightly increased risk, but it is certainly not being the case as with some other diseases in the past, like childhood measles and all, where children were at very, very high risk and adults weren't. So I thought it would be just worthwhile if I just looked at some Ontario figures, and we're always hearing about how many cases, but I think it's really important, you always have to consider out of how many. So our Ontario population is 14.5 million, and the overall incidence of COVID-19 positive cases has been about 0.2%, and the death rate has been 0.02%. So it's really a very low percentage, and that's for all over. So as far as going to school, right now, the incidence of COVID positive cases is low as compared to the peak in April. And of course, we're all hoping that it will continue that way and that we won't have a big second wave or something like that. But I think that every family needs to weigh the positive versus the negative consequences of going to school or not going to school. And my feeling right now is that the benefits of going to school for children with Rett syndrome and children in general outweigh the risks. And so everybody has to, consider that. And it's also not just for the child who needs to have, physiotherapy, occupational therapy, speech and language, augmentative communication, but it's also for the whole family in terms of not wanting everybody to be staying at home and not being able to have the resources for, having a job, having the ability to carry on financially. That's my. The other thing is that there is a very good statement that has been put out by the Rett syndrome organization in the States, which Dr. Carter had forwarded to us, and maybe we could send that around to everyone as well. Hello?
Karen, you're muted.
You got to read my lips. I'm glad you could tell I was talking. I do this all the time. Are there any other comments about COVID from either people who have questions or doctors who wanted to add something to that before we move on? I'm getting a sense that it's very individualized, your decision in many ways, but especially medically, I think it's going to depend on what kinds of symptoms. So if in doubt, talk to your doctor. Before we go on to the next part, there were some questions in the chat, and I thank Dr. Carter for answering them in the chat, multitasking. But maybe you could just address that briefly for everyone. The questions are from other provinces, specifically Saskatchewan and Nova Scotia. Is there a benefit to coming to Ontario to the Rett syndrome clinics versus having your own specialist in province just take care of things? So Dr. Carter, can you just briefly address that?
Yeah, I think the philosophy of most of the Rett syndrome clinics is not to provide full care for your child. It's to advise you and your other care providers on Rett syndrome specific issues, just because we've seen lots and lots and lots of girls with it. So if you do want to come to a Rett clinic, I think it's advantageous, especially if you have questions or your specialists have questions that just want another opinion on what else should we be thinking about. Do you see this often in girls with Rett syndrome, that kind of thing? So it's not an alternative to your local care, but it could be an augmentation, and it's not necessarily an ongoing thing. It could be like a one-time consultation too, if you prefer. And Saskattoon is developing a Rett syndrome clinic. I think the person who's doing it is currently on mat leave, but when she comes back, I think they're good to go.
I think it's also important to remember that there are lots of really great developmental pediatricians who can help to take care of your child with Rett syndrome, and the allied resources. The good thing about our clinics is that we tend to have a multidisciplinary clinic, so it's kind of one-stop shopping. But in places where you don't have that specific clinic, you should still also have access to resources.
Sounds good. Thanks. And we have some comments appreciating all of that information. We're going to move on to a question about attention deficit disorder. This came up in our family group chat, and I said something flippantly like, everyone with Rett syndrome is hyperactive, not being a doctor, of course. So then I suggested maybe this person bring the question to the doctors. But the question goes like this: can you speak about the possibility of an additional diagnosis of ADHD for someone with Rett syndrome? My daughter is 6, and her high activity level has also been mentioned by her pediatricians. So they're looking at this now too, with the possibility of trialing a medication. Is this common? Does it already fall under Rett syndrome? Are there possible complications to think about? And I should mention that she also has sensory issues and sees an OT.
Yeah, I think that one was mine.
Yeah.
So, well, it's entirely possible for someone to have both diagnoses, given that ADHD is common, and especially if you have a family history of ADHD, it tends to run in families. It is difficult to diagnose in people with Rett syndrome because the criteria that doctors use to diagnose ADHD are based on neurotypical children. So a lot of the criteria are either difficult to assess in someone with a neurological condition, or just don't even apply. So I think the more important question, rather than should my child have a diagnosis of ADHD, is what are the symptoms that I'm concerned about and what can I do about them? And this person's asking about hyperactivity. And I guess what I would say about that is hyperactivity can be a lot of things. There are lots of things that can look like hyperactivity. What I mean by that is ADHD type hyperactivity in girls with Rett syndrome that are not that and would not respond to medications the same way. So for example, anxiety can look like that. Agitation can look like that because of a mood disorder, a pain, a frustration. There are movement disorders that girls with Rett syndrome can have that can look like hyperactivity, but really it's an involuntary motor action, and less likely something like a seizure or something. I think that's less likely. So I think the real concern here is what is the symptom? And is it a problem? Because if it's not a problem, then you don't need to have medication for it. If it is a problem, then the doctor should be trying to figure out what the cause is and then treat the cause. So if it's agitation, maybe instead of giving someone a stimulant, which is what we do for ADHD, you give someone a sedative, right? So it really depends on what the underlying cause is, and it's not always easy to figure out. Don't know if that answers that.
Are there any follow-up questions from the audience? I don't want to say whose question it was, hoping that
I guess I would just also add that in general, I
took
don't
care of it. Feel free.
I was just going to add that in general, there are not a lot of girls with Rett syndrome that I know that have a diagnosis of ADHD, and there are not many girls that I know who are on ADHD medication. And there are no studies to tell us whether ADHD medication is effective in Rett syndrome.
Dr. Sue, did you want to add to that at all?
Oh, she's back on video.
I can see you now. I'm just sending a quick message to the parent who asked that to see. But yeah, it does sound like the doctors are going to need to dig a little further. And then the medication is going to be another question, right? So if that comes up as a follow-up question, I'll let you know. We're going to move on to some GI questions, which, so the gut. So Dr. Carter and Dr. Sue together can sort of tag team these answers. The first one I have here is, actually this is about bladder, so not technically GI. Is bladder retention or dysfunction a comorbidity of Rett syndrome? In speaking to families, it seems more common. If it is a comorbidity, are there any published articles about it? So that actually, I think we were going to give to Dr. Cassidy. I just had it under the wrong section. Here you go.
Yes, I'm happy to chat about that. There's probably not as much published information as we would always like to have before we kind of dive into really specific answers about a lot of these things. I think that the answer is that there are certainly, symptomatically, we can see different sort of presentations of urinary dysfunction amongst women with Rett syndrome. And I did actually, if I'm just looking today, it looks like there was a paper published just this year that had a couple of women with Rett syndrome included in their population of people with various sort of rare neurologic conditions. So there's maybe a little bit of information, and who knows, maybe that means more will come. Certainly, I think that we can see at a younger age in particular, maybe issues like urinary tract infections and things like that. And that can sometimes speak to some underlying urinary retention. So if your bladder is not emptying properly and the urine is sitting there inside, then that can be a risk factor for development of urinary tract infections. Sometimes it's very difficult for us to know how much retention may or may not actually be occurring, because some of the ways that we would look for that, for example, like an ultrasound where we've had someone purposely not empty their bladder, and then we go for an ultrasound and then we purposely have them empty their bladder and then check again and see how much they've been able to pee out, is something that a lot of our patients aren't able to comply with. So it can sometimes be very difficult for us to sort of tell how much is being stuck inside. But I think that we hear from people, just sort of anecdotally, we hear that there are people who experience retention. And so what do we do about retention? It depends on the severity of the problem. So, you know, if it seems like it's either causing problems with UTIs, so urinary tract infections, or if it's causing any discomfort, then we can look into a couple of different strategies to manage that. The same way that we would for people who have neurologically based urinary retention for other reasons. So that might include things like using a catheter. It might include strategies such as doing timed toileting. So kind of, you know, planning to go to the bathroom and offering toileting multiple times a day, or double voiding. So like going to the bathroom and then going again sort of right after to see if you can squeeze out anything that was left after the first attempt. Sometimes we use medications, but I would say that that's less frequent for a retention type problem. So it really depends on the situation with the individual patient, I would say. But as I said, it seems like there's maybe a little bit of information out there. I think there was 5 women with Rett syndrome included in that one case that just came out recently, all of whom had described retention. So I don't think that anyone is alone in experiencing that.
Thank you. Again, if there's follow-up question for that, you can unmute yourself. I think that's something in our circles with ORSA it's just not something that has been commonly covered at our conferences. And then when the parents start to talk, realizing, oh, it is an issue, especially with the adults.
Yeah.
And they're wondering, well, why haven't we talked about this before? So it may be just unique to Ontario that it hasn't been a big topic of conversation among the families, but it's not a bad thing.
Schedule it in for next year.
I know.
Yeah.
Dr. Cassidy knows me well. We do catheter rotation several times a day at our house, so it's been the ticket for us, but it wasn't until we started keeping track of it. So it's something you don't really think of keeping track of until someone suggests it. So we are going to move on to GI. So the question, I'm going to put these 2 questions together. One is about how can we reduce bloating, and one is about what are some ways to help pass gas. I don't know if they necessarily tie together, but let's see if Dr. Carter wants to have a go at that one. Tell us about passing gas.
I see Vicki saying, yeah, Dr. Carter, you do it. Yeah, those 2 questions really do go together, and also questions about constipation, really, because the underlying cause is really very similar in everything. So the issue with Rett syndrome, and it's almost universal, is that the gut, which is basically everything from your mouth all the way down to your rectum, is a tube of muscle that it involuntarily contracts in order to keep things moving. Things being food, drink, and air. And it just is sluggish in Rett syndrome for reasons we don't fully understand, but it's a neurological phenomenon. And so in terms of gas, in addition to not being able to move gas as well, a lot of girls swallow air. It's called aerophagia. And so if you're swallowing lots of air and you can't push it out, you get bloating and gas. Flatulence, I guess. And so there's really no good medication for that. Some people have tried giving like grape water that you would give to a baby, and I think that's worth a try. I think that probably mechanical stimulation is probably the best. So, like the old burping the baby kind of situation, you're just trying to move it physically, get her moving as much as you can. If she's not ambulatory, doing like bicycle movements with the legs, or even some light abdominal massage could be helpful. And then if it's really a problem, you could think about whether she has like a bacterial overgrowth kind of problem, especially the aroma is particularly bad. So you might want to talk to your doctor about that. You can treat that with antibiotics. I don't know, Vicki, do you have anything to add to that? Okay, no, she says. Should I talk about poop while I'm at it? Okay, I'll talk about poop. Oh yeah, wind reliever yoga pose, says Jennifer Saunders. Yeah, very, very good. So in terms of pooping, so again, not having really good gut motility means a couple things. It can mean reflux, which you didn't ask about, but that is something that's very common, and then constipation, which is essentially just the fecal matter not moving through the gastrointestinal tract and making it more difficult for her to get it all out, basically. So the first thing that you need to realize is, is she getting enough fiber in her diet? Is she well hydrated? And if so, then does she need help getting it out? Not because she can't, well, yes, because she can't, but what we tend to do, and I think probably everybody already knows this, is recommend a stool softener. Typically we use PEG, polyethylene glycol, which is like Miralax or Storalax. And the idea here is just to make this, take the stool, and it basically just pulls water into your GI tract, and that will soften the stool and make it looser. And so that is easier to pass. And again, mechanically, it helps to let gravity, help. So again, keeping active, using a stander, things like that can be really helpful. And I think the other question under constipation was when should you worry? Was that it?
When should you be concerned? So yes.
So I think that the ideal is 1 soft bowel movement per day, which is not always achievable, but as long as she's going regularly and she's not straining, she's not having like tiny rabbit poos, then she's probably okay. If she is going more than a couple days without a stool, that's concerning, but fixable. Sometimes we'll just say, well, give her a little extra of the stool softener, maybe some stimulation of the rectum using like either your finger or suppository can help sort of get things going. And the worst case scenario is being so backed up, for lack of a better word, that you stop eating, you're very uncomfortable, and it can even lead to bowel obstruction, which is very serious. I don't see it a lot, but it could happen. So I think just making sure that you're on top of it and not getting behind the 8 ball in terms of letting it build up, because if it builds up too much, it becomes very problematic to get it out. And I've seen girls end up in hospital because they're so constipated that they, are having all sorts of other problems. So yeah, I think keeping on top of it is a #1 priority, right from childhood, right from very early on.
All right, thank you. We have more GI questions, but I'm just catching up on the chat here. Someone has suggested using oval for gas, and it helps. And someone started to type a message and didn't finish, so I'll get back to that. Oh, are Rett clinics aware of all the FDA inquiries about PEG products? I remember Dr. Bax addressing this at the last conference. So there's some information out there about them being a problem. Do you know what they're referring to?
I have a vague recollection of Kevin Bax saying, I don't remember what he said exactly, but yeah, I mean, generally there's some buzz on the internet. They're very safe.
Okay.
And we use them in pediatrics all the time.
Okay. So
I think it's also important to say that, sometimes parents worry about medications being habit forming and, becoming really dependent upon it. But both the bladder and the bowel dysfunction are related to the autonomic system not working well. And that's the system that just normally functions to keep your bowels and bladders moving properly. So if you have an autonomic system problem, as in Rett syndrome, then it's not one that you can grow out of, and it's always going to be a potential problem.
I just got totally distracted there because I see Dr. Budden has joined us. You're on mute right now, though, Dr. Budden. Do you want to unmute yourself?
Yeah. Such Budden, just call me Such, like fudge. And okay. I'm currently retired in Portland, Oregon, and just listening on. But I couldn't. We've had a problem with our internet here, so excuse me. But I did come in on the tail end of what you were talking about, the gas, etc., or the GI issues. I haven't heard what you said before that. I'm sorry. Just wanted to add 2 things to this. Basically learn from, just trying to take care of these children. over several years now. What we found was an old Indian remedy of using about 6 mustard seeds crushed and mixed with yogurt, a teaspoon or a spoon or maybe 2 tablespoons of yogurt. And the reason I mentioned this is we tried everything, and I finally learned this from a friend of mine back home in India. Mustard seeds, to get them everywhere, and they just crushed, so they're powdery. And actually, there's several families here who used it, and they came back and they said, it's wonderful, we don't have to give our child any medications. So that was something I learned through someone else and passed it on. So I'm sharing this with you. And the other thing is about constipation. I was invited to Italy, and I was seeing a lot of kids there, and everyone I asked, and they said, why do you always ask about constipation? And I said, because there's a huge problem. And they said, we don't have any constipation here. And it turned out that they've been using the Norwegian fish oil. And every kid I saw there was getting Norwegian fish oil. And they claim they don't have problems with constipation. So just 2 little things that I'm passing on to you folks that I learned through other people.
Thanks, Saj. It's great to see you. Feel free to chime in for any of these. We're still talking about the gut right now.
Okay.
So just because it makes more sense to me, we'll address some of these questions on the gut before we move on. And heads up, Dr. Sell, I'm going to jump to some of the neurology after this because you haven't had a lot of chance to talk. So there was, if we can back up one more step, there was one more question about bladder, Dr. Cassidy.
Yeah.
So it is, our daughter has backwashing. Did you see the question?
I just saw it, yeah.
Backwashing. So is this a Rett motor issue?
Well, I assume that by backwashing, we're talking about the problem of urinary reflux. So when you have urine that's building up in the bladder and there's just essentially too much in there and it's not coming out, it has to go somewhere, so it goes up. So it goes back up the tubes towards the kidneys. And that's obviously not where we want it to go. We want it to go down and out. So I think that I don't think that any of us could clearly say that that's related to a motor planning issue, because the way that the bladder functions has nothing to do with sort of voluntary motor activity. So it's not about planning, it's all sort of reflex based. So as Dr. Sue already mentioned, this has to do with the autonomic nervous system and sort of regulation of a number of reflexes that have to occur in a coordinated fashion for your pee to come out when it's supposed to, and as much as it's supposed to come out comes out all at the same time. So it's not so much a planning issue as sort of like a reflex discoordination issue, I would say. And the other thing that I wanted to mention, just since I have the floor again, is that when you have constipation, it also contributes to urinary retention. So just another plug for making sure that the bowels are moving, because certainly we see that if one side's not working, the other side stops working too.
I can vouch for that. The question from Jen is there a connection between seizures, Rett episodes, either or, and dysmotility of the gut? Who wants to take that? Dr. Sell?
Sure. Well, there is a connection in the sense that they're all driven by nerve endings. So it's said that we actually have like more neurons in the gut than in the brain in terms of numbers. So it just makes sense that if there is a common denominator of electrical or chemical talking between these type of cells that is not always perfect, it can affect not only the way the brain fires, but it can also affect that connection with the gut. And that's let's say the connection between the gut and the brain. Now, in terms of more specific practicalities as going straight into treatment. So can we expect that the gut is going to improve as we improve seizure control? I don't think so. So to the best of my knowledge, that has not been established. so we have this common denominator I was talking about, but treating one doesn't automatically have an effect on the other. It works a little bit better backwards. So often, if there is significant constipation and gastrointestinal problems, some families will find that seizures get worse. And once this is solved, sometimes seizures improve somewhat. But the connection can be of multiple other factors. So you have to throw in the pharmacokinetics and pharmacodynamics of the medications that you're taking on a regular basis, and how this is affected once you improve your peristalsis or your intestinal movements, right?
Thank you. We did have another parent suggestion that a probiotic works well for GI movement. And one more, back to Dr. Cassidy, one more bladder question there. I don't know if that's a question necessarily. Our daughter may have pain for 30 minutes and then a huge pee that saturates her diaper. So what's happening there?
So it's hard to be sure, but just as we were talking about that discoordination, because again, there's a number of different sort of neurologic reflexive processes that are happening in order to coordinate that bladder emptying. So you can imagine that sometimes if that's not working well, so I think of the bladder like a balloon, except for the balloon has the door at the bottom of it. So in order to get the pee to come out, you have to squeeze the balloon and open the door. So you can imagine that if you squeeze the balloon, but the door is still closed, then that might be uncomfortable. So, if something like that is happening, then once the door lets go and the pee comes out, that would obviously offer some relief. In theory, I don't have any real suspicion of this based on the description, but, if you are having significant urinary retention, then you can also get into difficulties with bladder stones or kidney stones. Those would typically not be sort of immediately relieved with a pee like that unless the stone actually passed, which would not be sort of a quick and easy process that happens sort of routinely over and over, which is sort of what it sounds like is being described. But if there was a lot of sort of flank pain, especially sort of pain that kind of comes and goes and grumbles on and off, and that would be pain sort of on the sides or the back, but sometimes obviously difficult to tell if our patients can't tell us exactly where it is, then that might be something that would be worth investigating for if that's happening frequently.
Okay.
Karen, may I add just something really simple that we found was useful for families, especially if it was in the middle of the night or, they couldn't get to the hospital, didn't have any proper help. If we took them to the bathroom, set them on the toilet, and let them sit there and turn on the shower, the faucet, let the water run, and let them, and put a warm hot water bag on their tummy. Sometimes they just pee. So it's been, those are things that sometimes we have to do, especially in situations where they don't have any other type of help available. And it has worked for several families. But it's just something simple.
Good to know. I feel like I need to go to the washroom now.
That's right.
We are going to carry on with the gut questions that were prepared here. And I will get back to the chat. You guys are going nuts over there now. Parasites. Dr. Sue, the question is, are internal parasites common in Rett syndrome with individuals who have oral fixation? And are there supplements or medication to take to avoid parasites?
So parasites in general are not common just anyway, but I think the important thing to realize is that how parasites are propagated, and that is primarily through what we call the fecal oral route. So it's the parasites can be in the bowels, and then they come out with bowel movements. So the way to avoid getting a parasitic infection is to use good hand hygiene, and particularly around toileting. Of course, most girls will not be toileting themselves and wiping themselves, but washing the hands all the time or keeping them clean after using the toilet. So I don't think that girls with Rett syndrome are at any increased risk per se, but of course, if they're putting their hands in their mouth after they've touched some contaminated situation, then they could get parasites. There's no indication at all to use any medications to prevent parasitic infections, but there are medications to use to treat them. And one of the most common, if there is a parasitic infection, is giardiasis. With giardiasis, you actually get malabsorption, so you get more stools that are loose. So I suppose if you had a child who's got a lot of constipation normally and suddenly starts having a lot of loose bowel movements, then you could suspect there might be a parasitic infection, but it's very unlikely.
This next one I'm going to ask Dr. Sell and Carter, between the two of you, to answer, and it's about the shaking spells. So this is about a 10-year-old who has shaking spells, and then sometimes a burp will come during it and the shaking stops. There's also something about, she will hold her breath and her eyes might roll and her lips might turn blue. But she's wondering if that's related to gas or if that's something else to be concerned about. Sorry, that question wasn't very clear, but do you think burping is going to stop? Like, is that a coincidence that the burping stopped the spell, do you think, or is there some connection there with gas?
Eric, do you want to take that one?
Sure. Well, these kind of situations is not unheard of. Often what happens is that you're not dealing with a true epileptic seizure or something is so involuntary, but rather a discomfort. And then the way that you react to it, so the way that you may either posture, shake, move, sometimes is kind of like a behavioral response to what is bothering you or what is affecting. And once you get through it, then you feel better and you stop doing. So that is probably what is happening, just borrowing from similar experiences. But yeah, the fact, if it is that consistent that it ends with a burp, is probably in that sequence.
I've definitely had, sorry, Karen, I've definitely had parents tell me similar stories. I had one patient who had such severe spells due to gas pain that the parents almost put in a G-tube, not because she needed to eat, but just to vent the gas. They didn't in the end. I think she got better fairly spontaneously, but yeah, we've seen that for sure.
So it sounds similar to the distress that's being caused that might show up with symptoms that look like something else. Anyway, it just reminds me of your hyperactivity talk there, that it could be from the gas. Before we move on to the neurology questions, there were a couple, just one more thing here about poop and a suggestion about the foods that you eat. So lots of prunes and fruits and vegetables and water to keep you regular. And also this person, they use magnesium glycinate sometimes as well. So that's a parent recommendation. And I think the doctors will talk about that in the clinics a lot too, to look at your nutrition and your water intake. So we're going to move on. We do have other types of questions, but I want to focus for a few minutes on seizures or Rett episodes, depending on what we're talking about. And we'll direct them to you, Dr. Sell, but anyone else can jump in if you want to add something. If you feel your loved one is experiencing Rett spells or episodes or seizures, what's your first step? So this is, I guess, before you're diagnosed with any kind of seizure issue.
Yeah, I think that it comes down to seeking an assessment by your doctor. And like you mentioned, all opinions are very much welcome, because not all these spells are going to be epileptic seizures. As a matter of fact, many will be mimickers. Some are going to be relatively easy to tell, and some will be very difficult. So the first step is to try to do a little bit of a detective work at home, looking for those factors or those circumstances when these spells happen. So do they happen when you're awake, when you're asleep, after eating, before eating? How do they affect what you're doing at that moment? Do they completely make you grimace? You keep your eyes open? So all of these descriptors are really key to try to pinpoint what is going on or the nature of it. Then there are ancillary testing, like other tests that sometimes can give further information. We have had girls that have a very good description. Sometimes we get home videos, which are also a relatively newer and always welcome tool. So home videos are priceless. But even then, sometimes we have these so-called freezing episodes or postures, and when we really cannot move forward identifying the nature of it, we sometimes resort to recording with electroencephalogram and video at the same time. And that is the gold standard to try to discern if something is epileptic in nature or not. Once we have made that step, either by history or with help of other tools, if these are epileptic seizures, then it's a matter of finding treatment as necessary. If these are not epileptic seizures, then more often than not are going to be behavioral driven movements or pure movement disorders. So things that have to do with not having complete control of the tone, the movements, some of which will have a specific approaches to lessen the burden and make it better. So that I would say is the initial approach.
Okay, thank you. So you've covered a lot of these other questions too. There is a general question about drugs are there drugs, if it's not seizures, are there drugs to recommend for Rett spells, whatever you want to call them? I think you've kind of addressed this, but.
Well, I can mention a couple, and my colleagues probably have more information. There are medications like Artane or similar that have been used sometimes to treat spasticity, rigidity. They have sometimes their own side effects and their limited efficacy in many instances. So there are medications that, yes, can be used for problems with movement and posture that are not epileptic in nature, with that big caveat that sometimes the improvement may be partial. Then for breath holding spells, there is some anecdotal experience with some medications that have an effect on the acidity of the blood, or anticonvulsants like Topamax that have some effect on regulating the gases and the acidity, and that as a result of that side effect, it can decrease or ameliorate the intensity of some of the breath holding spells. But again, this is more anecdotal.
Okay, thank you. There's the question about food and controlling seizures. So it's a pretty general question. I know there's specific diets people use, but this one says, how do you use food to control seizure frequency?
Well, since I'm is on the phone on the speaker, I might as well elaborate on this
All
one.
you.
There is one specific diet that is a medical diet. It's called the ketogenic diet, and it is a diet that yes, can control seizures for some individuals, or can improve seizure control for some individuals. It is not, even though we use the word diet, is not necessarily benign in the sense of side effects. It is essentially inverting the pyramid of how much calories we get from carbohydrates like pasta, bread, rice, compared to fat. So of course you can imagine that the moment that you switch that balance, you're gonna be eating a lot of dairy, a lot of fat, very little carb, and you have to be careful because this is already a recipe for disaster when someone is constipated. Now, it can be done, so that is not an absolute contraindication, but I mention it because often, just by popular culture, we look for the natural and we look for the the food and to avoid pharmacotherapy. But ketogenic diet, it has side effects just like medications
Hey,
do.
Blair, stop it.
Hey, Carrie Ann, we can hear you.
Breath.
Sorry about that. Carrie Ann, do you have a question? I think that was an accident that she unmuted. Okay, so we're gonna ask you about dystonia for a minute. There were two questions that came up. One is just generally what is dystonia and how can you help someone with it? And then there was a question about athetoid movements in Rett syndrome. I don't even know how to say it. And is that related to dystonia?
Yeah, so this is probably an answer I should share with my colleague physiatrist, because dystonia is, I always think about it as an abnormal movement that results in abnormal postures. Sometimes it can be discomfort in the sense that it can be bothersome if they are very sustained, and it can contort a limb or the entire body depending on how the dystonia is distributed. But the way I see it, in maybe an oversimplification, is that when we are trying to move, we have to relax a muscle and contract another one to exert a specific type of movement. And when this is not coordinated, and then we get both or more muscle groups contracted at the same time, and then not only we cannot move properly, but we're contracting almost like a spasm, many different muscles, and hence the postures and the discomfort. Unfortunately, I don't think that there is like a great treatment for dystonia. It's sometimes treated with medications that are intended to control seizures and have some effect over dystonia, or medications to control spasticity and rigidity and have some effect over dystonia. Sometimes I personally consult a colleague from physiatry to ask if there is any role for any other kind of like muscle relaxant, even sometimes Botox injections. But again, unfortunately, there is no silver bullet for dystonia.
Okay, we'll turn it over to Dr. Cassidy. In the meantime, Dr. Sell, if you can access the chat there is a follow-up question about the food and seizures, which we'll come back to. So Dr. Cassidy, can you tell us something about dystonia?
Yes, I'll just echo a lot of what Dr. Sell was saying. So dystonia really just refers to this sort of abnormal movement of the muscles in a way that is outside of an individual's voluntary control. and it can lead to these different postures. And there's a spectrum of abnormalities that we see. And dystonia is sort of one type of movement disorder, but there are others that we can sometimes see manifesting, and often, especially as our young women with Rett syndrome are aging, we see a lot of what I would describe as rigidity. So the muscles can become very tight, with the limbs kind of trying to stay in one position and being difficult to bend or stretch out. And I would also agree that unfortunately there's not a lot of great medications for this. So depending on what type of movement disorder we're seeing predominantly, so whether it's something that's a little bit more fluctuating or something that's quite rigid and fixed, we might choose to try different medications. All medications have potential side effects and downsides, so we really have to choose wisely, and we make our choices based on family goals. So just because there is tone doesn't mean we have to treat tone. So, you know, and it's really a question of whether or not the tone is bothersome or interfering with care, comfort, or quality of life. And if any of those things are occurring, then it may be very well worth a trial of one or more different medications, up to and including injections with botulinum toxin, which we can do. And obviously the difference there is oral medications affect the whole body, botulinum toxin injections affect the one area where we target the injection. So if it's a problem just in one small body part, then botulinum toxin might be a very worthwhile thing to try. The success rates would be variable. As I said, it's unfortunately not something that we have sort of that one great treatment for, as Dr. Sell said as well.
Karen, may I ask a question, or may also make a comment? I haven't had much experience with dystonia, but I do recall a girl who's still alive, actually, and much older, and she had significant dystonia. She, in fact, came in and was so dystonic she could hardly breathe. I mean, she had her bowel, her bowel was full. She couldn't pee. I mean, it was horrible. And she was in the hospital and she was having seizures. And I called around to my pediatric neurology friends internationally and found out that maybe we could give the girl some Dobrinol, which is actually a derivative of Marinol. It is Marinol, derivative of marijuana, which is currently being used in many places. And we gave her 2 milligrams, and it was amazing. I mean, she emptied her bowel, she kind of woke up, and she wasn't breathing heavily. And like I said, she's still alive. She continued to use 2 milligrams for, I think, about 5 or 6 months. And then she was fine. And I think she's totally off it currently. But it was something that I learned one night on a Sunday night. I called around really trying to get people to help me, because I'm not a neurologist and nobody here had any answers. So I'm just sharing this with you, and maybe Dr. Sells, I think you possibly could help us here, whether that's been tried. I do know that some of the people in Seattle have been using Marinol, but I don't know if any of you are familiar with it. I personally have not used it, so I don't have a lot of experience with it except with that one girl.
I might just have a really quick comment to that. So cannabinoids or marijuana derivatives are certainly being used, I would say, more and more amongst our patients who have different movement disorders for many reasons, certainly not just in the Rett syndrome population. Our conversations with families, at least amongst myself and my colleagues, I think are largely about sort of providing education about what is known and what is not known. So there's not very much that we know. There's not a very good evidence base really at all for how and when to use these types of medications. So really it is about sort of education about risks and benefits. So for many patients, it makes sense to at least try these medications, taking into account other risks, obviously including things like their seizure control and other considerations. But I would say that our success rate with them is not dissimilar to our success rate with many of the other medications. So it seems still quite hit or miss. We have lots of patients who really don't have a great response with it, and lots of patients, well, you know, sort of this like, it kind of works or it doesn't work. So it's very unpredictable in my experience who it will work for and who it won't. And so it really is a conversation about who would like to try it and who wouldn't, and in which situations would we think it's safe, and in which situations would we recommend against it.
Yeah. Well, thank you.
Anyone else, Dr. Sell?
Just essentially to agree with all just said, that has been the experience for us at CHIO as well. And the same thing for even patients with non-Rett similar syndromes.
Dr. Cassidy, do you have any input about this question about mood after a dystonic episode? My daughter's very happy and smiles a lot. Is there a connection? And this parent has heard this from other families.
I don't know that I can speak to a definite answer to that question, other than I think it's wonderful that she's happy after she has these dystonic episodes. Because, you know, none of us really know what our patients are experiencing when they're going through these episodes. Sometimes dystonia can be in response to a negative stimulus, but dystonia by its very nature is essentially just stimulus responsive. So there's nothing to say it couldn't be in response to a positive stimulus. So dystonia could be experienced because of something that's caused some kind of a positive response for any number of reasons. And so maybe the dystonia is just what you see first, followed by the smiles after. So dystonia does really fluctuate. It could be negative or positive, whatever brings it on.
Cool. Okay. We're going to move on to the prepared questions about, there's one about vaccinations. And Dr. Sue, I think you could take this one. Would Pneumovax be recommended as a vaccination for Rett syndrome, people with Rett syndrome, or should it be avoided?
So I think that, and this was also related to for preventing bacterial pneumonia. Excuse me. So the important thing is that not all pneumonias are due to pneumococcal infection. Many types of pneumonias, especially like an aspiration pneumonia, it's just caused by aspirating into the lungs, and often some of the bacteria that are resident in our mouths. Pneumococcal vaccines are given to all children as part of our Ontario and Canada-wide immunization schedule. So children get that in their before they're 2 years of age, and then that should be enough to cover children, so that especially since pneumococcal infections are particularly common in younger ages. So I don't think that there's any indication to give children with Rett syndrome additional pneumovax vaccines. And the primary time when we use those are when children are immunocompromised, especially if they've had their spleens out, or if they have sickle cell disease and certain other indications.
Thanks. Yeah, typically, and this was not a question, but just to make sure we're not, in case this is the intent of the question, typically pneumonia and Rett syndrome, what would typically cause that if it's a Rett syndrome specific issue?
So pneumonia oh, sorry.
No, go ahead.
Pneumonia, most often pneumonia just in general is due to viral infections. So influenza and other viral infections, and children with Rett syndrome can get those types of infections as well. If we have a child, though, that has any kind of swallowing difficulties, then they might be at more risk for an aspiration pneumonia. And again, that's just when they instead of swallowing their secretions, they go down the wrong way into the lungs. And then we have the bacteria in our saliva. So bacterial infections, though, are ones that can just happen, that you often they might actually start from the blood and get into the lungs. Bacterial infections are much less common, and girls with Rett syndrome or women with Rett syndrome are not particularly at increased risk for those.
Okay, thank you. There's another nutrition or supplement question here. Is there any increased benefit to taking coenzyme Q10 or other supplements for optimizing health in Rett syndrome?
I guess I can start. And then, yeah, I guess I'll start, and then if anyone else wants to add anything. So coenzyme Q10 is what you call an antioxidant, and there are lots of antioxidants. In fact, you get them in your food and lots of other things. And those of you who are have been following the story with the clinical trial that's going to go on at Bloorview, very soon, we'll get started, I understand, will be a clinical trial where they are comparing a antioxidant cocktail, which is basically vitamins and antioxidants, and trying to answer this question, or parts of this question. Does it do anything, or is it more like placebo, basically? And so that's really an interesting area of exploration. We don't have answers yet, basically. In general, when it comes to supplements, the only ones that I routinely advise people to take are vitamin D, because there's good evidence that supplemental vitamin D is good for your bones, and girls with Rett syndrome have higher risk of osteopenia or osteoporosis. So I tell everybody, in fact, I take it myself. So, I mean, I think everybody should take it probably, and it has lots of other health benefits as well. A lot of people ask about this supplement or that supplement, and I'm not an expert in natural remedies. Some people will consult a naturopath. I generally think they are probably safe, but you should check with your doctor, a doctor who knows your child well. Check with your pharmacist. Make sure if they're on any other medications that it's not going to interact or have a negative effect on them. And then there are others that people often use, which I think are fine, like probiotics, for example. I think somebody mentioned that in the comments for gut health. And I don't know what the evidence is for it, but I know a lot of GI doctors, including, oh gosh, her name is escaping me, but the GI doctor that is involved in the Rett syndrome trials in the States. Oh, so embarrassing. But anyway, she often recommends that.
The Dr. Motil.
Motil, thank you. How could I forget that? That's the perfect name for her. Yeah. So yeah, as far as supplements, those are the main things. I don't know if other people have other thoughts on that.
Going. You can add your thoughts into the chat if you need to. Teeth grinding. Any recommendations for? It says for teeth grinding, but I think we're talking about preventing it or making it less intense.
I know we've had one family who found that putting Invisaligns on their daughter's teeth made a difference. I think they were originally using the Invisaligns, so just the ones to help to realign her teeth, but they found that that really improved with some of the tooth grinding, and it certainly also protected the teeth from being ground down.
That is genius. I have not heard that before. I don't know how expensive that is to do. I've never used Invisaligns, but this is a super common question. Grinding of teeth is very annoying, right? And so it's hard to deal with. And also it can hurt your teeth. Like it can wear down your enamel, make you more susceptible to cavities and that kinds of things. So I always recommend, well, first of all, kids often grow out of it. So, I mean, not everybody does, but sometimes it's just a phase. Putting something between the teeth, like jewelry, you know, that you can put in your mouth and sort of distract her from putting her teeth together, might help some people. But I really always recommend a good dentist to answer some of those questions and make sure that the oral health is good and look after the health of the teeth. I don't know if anyone else has any suggestions.
I was just going to add, so it's interesting to hear you say that some people grow out of it. I definitely think maybe some people grow into it. So seeing the older population, this is something that comes up not infrequently also. And the one thing that I would add, I mean, it's obviously not an easy problem to solve often, but I would say that this could actually be a form of the dystonia that we were talking about earlier. So some dystonia involving sort of the clenching of the muscles that control the jaw. And so we have actually had some good success with small doses of botulinum toxin into the facial muscles that control that jaw movement. There's obviously, every time we do a treatment, there's discussion about risks and benefits, but with the small doses, it seems to give it some benefit for certain patients.
Thank you. Therapies, Dr. Cassidy, will let you do this one too. What therapies generally do you recommend for everyday living?
So I hope other people have insights into this as well, because when I read this question, I thought, oh, holy smokes, there's so much you could say about that, but also it might be so different for so many different people. So it's kind of a hard one to answer. I think that the underlying principle of the answer is that there's not necessarily one specific therapy that's going to be the be all and end all of a plan for every young woman or young girl with Rett syndrome. What we want to do is encourage movement, weight bearing, exploration of the environment. We want to encourage that cognitive development, social interactions as much as possible. So that's going to look very different for different people. So, physiotherapy is so important so that they can, work on different strategies to allow that mobility. So if, the patient is not able to be ambulatory on their own, are there different strategies, supported walkers, wheelchairs from a young age so that people can explore independently? All of those things should be considered early and often. Stretching might be very important together often with things like bracing to avoid contracture development. So we talked about that tightness in the muscles, particularly that we see later in life. And when the muscles get really tight, then sometimes we develop contractures, which means sort of a fixed limitation of range of motion. And once that happens, that can be very difficult to reverse. So we really want to do as much as we can from as early an age as possible to just have natural movement of the body in as many ways as we can. I don't really know how to be more specific than that. So, that might include OT to make sure the upper extremities are moving and to encourage that cognitive development. That might include SLP, obviously, because SLP will also work on the speech and language pathology. That will also work on the cognitive development, the language development, and not just expressive language, but also understanding and interacting. So that might include things like augmentative communication, the physiotherapy we talked about, and things like play therapy, recreation therapy, just getting out and getting involved, finding things that your loved one enjoys doing and it isn't sort of a chore or a task, because we really don't want it to be something that our patients or our family members are hating to do. You don't want it to be something that becomes a problem. You don't want it to be something that will eventually lead to negative behaviors and things like that. So as much as you can integrate that sort of regular play and therapy in a way that's fun as much as possible. I know probably people are thinking like, it can't all be fun. And of course it can't all be fun, but as much as possible, because we do really want it to be a lifelong thing to encourage sort of that healthy development all the way through. I'm sure other people have thoughts on this, but.
Feel free to chime in.
I just want to stress the importance of the eye gaze communications when we're talking about augmentative communications, because, and I think Karen, you certainly might want to speak to that, but.
You're getting a clapping emoji from Jennifer Fetch. No, I can't see your name, Jen.
Yeah, so really so important because of course, definitely physio and occupational and movement and being involved is so important, but the communication is paramount, I think, as much as we can encourage it.
Yeah, and there are lots of parents who can help out with getting you connected with that too, if you're just in the beginning of your journey.
We have encouraged swimming if possible, because there are several families that really can get to the swimming pool, and the kids just love it. The first child who started to really walk was in the swimming pool, and in the good old days when they thought they'd never walk, that's when she started to walk, and we've learned a lot from that. I think there's other families. Well, it depends where people live because we are fortunate living in a place where there's lots of horseback riding. There's outdoor activities, and so we really encourage the walking, the swimming, the horseback riding, if possible. And I think most of you know, I mean, have talked about therapy at home, etc. But some of the things that we normally do is nice for the children to do because it makes them really be part of the their uh, their sibling group or their friends or whatever.
I just want to echo something that Vicki said about the importance of the communication, because of course I take care of the transitional and adult population. So first of all, independent communication is such a huge part of us being able to identify problems when we're starting to see behavioral changes. So that is such a huge thing. If our young girls or older girls or women can tell us something, any little seed about what's going on that's bothering them, that can really lead us down a path. And the other thing is, if they can give us any little indication, any little seed, that's so important as they age, particularly if they're going to be dependent on other folks, like people who are not their parents. Their parents are often so in tune with what their needs are and what small behaviors might mean in terms of what their loved one needs. But later on, that person, those parents may not be available to direct the care as much as they had been in the past. So if we can develop that sort of competency with communication, it makes a major difference for us unfamiliar care providers down the road.
Dr. Carter.
Totally agree with everything that everybody said. There's a really long list of potential therapies that can be tried, and there's not a lot of empiric evidence for many of them. But I just kind of want to touch on the fact that therapies are expensive and time consuming, and try not to let what other parents are doing and telling you they're doing with their kids make you feel guilty that you're not doing them for your kids, because there's no right answer here. I mean, I think communication, taking advantage of the communication and the physiotherapy resources is really key, but everything else is, as Dr. Cassidy said, very dependent on the person. And, you don't have to put your kid in every single therapy. That's just what I try to tell people, because I don't want you to feel like you're not a good parent if you don't put them in everything.
That is such a good point.
Thanks for that.
Because you are not the therapist. You're the parent, first of all. Yeah.
Good point. Good perspective there. I'm just losing my papers here, losing my mind. Scoliosis. Do we want to talk about that next? What can we do? Is there something we can do to prevent or correct it? And there's a follow-up question, but I'll let you go with that first.
Sure. So scoliosis obviously is maybe not obviously. Scoliosis is a curvature of the back, which is a common problem in many populations of people who have different neuromuscular or neurodegenerative conditions. So it occurs at varying rates. We have people who have very significant scoliosis from a younger age, and then people who have quite minimal scoliosis even at an older age. There's not really any good evidence that there's a great strategy to prevent scoliosis. It kind of is going to be what it's going to be as far as sort of its initial development. There's no evidence that, for example, relating to our last question, you could do physiotherapy all day, every day, and you would not be able to prevent scoliosis. This is not a failure of provision of therapy or anything else in that sense. Sometimes people use bracing for management of scoliosis, and that really depends on the patient. Bracing is not appropriate for all patients. So depending on the individual, that might be a reasonable choice, but the bracing really does have to be on for the vast majority of the hours in a day to provide any benefit. So most people would say it really should be on for 23 hours a day. Although some people would say more like 16 hours a day. That's to let people kind of out of it, actually to go to school if that's a problem with acceptance. Most of our patients will not be super successful with bracing. Patients who are non-ambulatory, we use custom molded seating in a wheelchair to support the back in sort of its best available position without overcorrecting to cause discomfort or issues with skin breakdown. So we really just want to try to hold the back in its best position and not allow it to continue to progress. And then the other option is surgery. So surgery is obviously a major big deal. It's a really big surgery, but it's appropriate in certain situations as well. So that would be a decision made together with an orthopedic surgeon with input from many others. Oh, and there's a comment.
Yeah, there's some comments about it. Our daughter slept in a brace for a year and her curve did not change, but think it really didn't help.
Yeah. So, and I mean, again, bracing is quite individual. So there wouldn't be a lot of great evidence for bracing in what I'm going to call neuromuscular scoliosis, meaning scoliosis that occurs in someone who has some kind of neurologic or neuromuscular diagnosis. But that said, again, it might still be worth trying in certain patients because it's much less invasive than a surgical alternative. So there are times where we might at least want to kind of give it the old college try and see if it can prevent that progression.
Can you tell us anything about vertebral body tethering surgery? Is that something that happens in Rett syndrome ever?
I cannot tell you very much about vertebral body tethering surgery. So that obviously would be a question that you would be discussing with the orthopedic surgeon, because if you've gotten to the stage where you're considering that, they'll be looking at sort of whatever option seems the most appropriate. I don't know if this question is about looking at sort of a mild scoliosis case and determining whether or not you want to do this as like an early surgical intervention, but I have certainly not seen that occurring. I don't know if any of the other folks here have seen that, but I have not.
Okay.
I'm going to say there's if we're talking about vertebral body tethering as infusion of the vertebral bodies, there are different treatments for scoliosis because there are different types of scoliosis. So there are some kinds of scoliosis which do not occur in girls with Rett syndrome, in which their bones are actually underdeveloped. And in that case, sometimes we can predict that those individuals with abnormal vertebrae will benefit from fusing their vertebral bodies together so that they don't get a very drastic scoliosis. But as Dr. Cassidy said, in Rett syndrome, it's more of the, I think of it as uneven muscles. So just as you have dystonia and abnormal muscle contractures of the muscles, it's the same thing in the back. You have to have, in order to have a straight spine, you have to have all those muscles squeezing down in a very symmetric fashion. And in girls and women with Rett syndrome, it may be uneven, and then that starts to move the spine to become not straight.
Yeah, and we have a comment in there that you guys can look at about a surgeon who didn't recommend it for Rett syndrome. There's another scoliosis question related to endo. So is there a relationship between bone health and scoliosis?
So I would say that, and if anyone else wants to jump in, please feel free. So in the setting of reduced bone density, one of the things that can happen is vertebral body compression fractures. And so so that's like, you know, your vertebral body is like a block. And if you have a compression fracture, then you can get sort of a wedging down on one side compared to the other. And if it wedges down, then that could contribute to the progression of scoliosis because they're all meant to be blocks sitting on top of each other. If one side shrinks, then you can see how that whole tower might start to topple. So that could, in theory, lead to a more rapid progression of scoliosis. And so obviously that would be something we'd like to try to avoid with strategies such as weight bearing when possible, calcium and vitamin D supplementation to encourage that good bone health. If bone health is an issue, then that will be something that will be taken into account during surgical planning because if the bones are not sort of robust to put the hardware into, then the surgeon may need to sort of adapt their surgical plan to make sure that they have some good solid bone to kind of stick their metal to. But that would be sort of the linkage that I would say there.
Yeah, this parent is saying that they found after pomidronate treatments that the scoliosis was reversed by 18 degrees along with physiotherapy. So, I mean, I guess it's a question of correlation. based on that
Yeah.
anecdotal.
And it's also a question of sort of what the nature of the scoliosis was prior to its onset. So some scoliosis we would describe as sort of more functional. So, talking about how physiotherapy may have played into that as well. If part of the scoliosis is more about posture and positioning, and we can address some of that with physiotherapy, as well as preventing any further deterioration in the compression fractures, if any existed, then you can see how that might be able to correct itself without needing anything more dramatic. Physiotherapy is often quite sort of a difficult concept to describe in relation to scoliosis, because there's no good evidence to suggest that physiotherapy will actually change the curvature if it's quite fixed. But sometimes it's difficult to determine if it's actually fixed or if the person is just kind of in a habitual, sorry, I know you can't see me with my light going on, but if the person just has sort of a functional postural change, we might not really be able to appreciate that clinically. It can be hard to sort of correct that when we do the measurements. So sometimes, we say that physiotherapy, quote unquote, doesn't really work for scoliosis, but it may sort of work if the scoliosis isn't stuck, if that makes sense.
Makes sense to me. There was another question along that line in the prepared questions about, which really relates to seating, I think. So an individual who is very non-mobile, doesn't weight bear, worrying about whether she's having pain based on scoliosis and how she can be lifted comfortably and seated comfortably. So does anybody want to talk about seating and positioning?
So I can talk about that as well, unless anyone else wants to jump in. So for someone who is using a seat for most of their mobility, we would typically recommend custom molded seating, particularly if postural control is an issue. And so that would be done together, usually with an occupational therapist, making sure that, again, that spine can be positioned as well as possible without causing discomfort or pressure areas that might predispose to skin breakdown. So that's the seating question. Sometimes the seating can be quite unique, and that's the idea of making it custom. So we really want to be in a position that will appropriately support without causing discomfort. And in terms of the lifting, I assume talking likely about mechanical lifting based on the nature of the question. So that would be using like a sling and then like a ceiling lift overhead or a portable mechanical lift. And so usually the comfort with those, the best thing that you can probably do is experiment a little bit with different types of slings. So there's a lot of different slings that come up, to varying degrees under the neck, that come up to varying degrees sort of under the back. Sometimes you can, people prefer slings that actually leave out the back end, or the back side, I guess I should say, completely. So we would call these like a hygiene sling. So these wouldn't come under the bum. So that makes it easier to transfer like on and off of a commode or in and out of a back seat. But that said, sometimes people for non-hygiene purposes might find that it's more comfortable to use something that gives them more support all the way down under the knees with some harnesses that come right down under the legs. So, and even, amongst those types, there are different fabrics you might be able to find from different providers. And so I've had people who've been very uncomfortable with certain slings and have been very successful with others. So that's sort of the best you can probably do from a lifting perspective as far as comfort goes. If there are certain areas of pain, obviously, then you should speak to your physician about a physical exam of that area and see if there are targeted treatments that might make them more comfortable in seating or while they're lifted.
Thank you. If it is a little one and there's caregivers lifting them, that would be an OT probably that would help out with that. Am I right?
Do you mean transitioning, like if they need to transition? Yeah.
Lifting the person still to different positions.
Yeah, so an occupational therapist should be able to kind of help make recommendations, and then they can also help you to find appropriate vendors who would be able to actually operationalize that in your home.
Mm-hmm.
I just had two comments. One was that we know that the majority of the children develop scoliosis, and some earlier than others. And usually when they're younger and you tend to watch them when they walk, they're either with their hands together and heads bent one way or the other, mainly to the right or the left. What we decided to do is to have very soft elbow splints so that they couldn't get the hands together and hold them so that the hands were down there unless they were doing some activity at the table, etc. And if you watch them walk before and after, you find that their posture is much better, their heads are higher, and their hands are down, so they're not kind of walking to one side. The other thing was the older kids, and if at all possible, using horseback riding has been a big thing, and it's expensive. It has to be figured out, but in our experience with the children using horseback riding, we really did find a definite decrease in the number of children that had postural problem, scoliosis. The person that's currently following up on that is Mary Jones down in California, and I've watched that, and we've had girls over here. So I think that there are different methods of doing it. Horseback riding can be expensive unless we have some of the therapists that have literally actually donated their time to doing this. But I think using just soft splints is very, you can take them out whenever you want to. It's not something that's put on there. It's something that you can put them on as more like little braces that we use.
Thank you.
We've certainly seen those elbow braces be very effective also in just freeing up, especially if we do a brace on just one arm, freeing up the other arm so that they can actually have purposeful use of their hands. And it's really quite amazing. Yeah.
Totally agree with that, yeah.
I just wanted to make one comment because I see there's a lot of things about the scoliosis and surgery. And what I said earlier, I may have misunderstood what was actually the question actually was. If it was a question about insertion of rods to straighten up the scoliosis, I don't think there's any orthopedic surgeon that would do that to prevent scoliosis. It is major surgery, and that's why we try to do things like, even if there was a comment of somebody having had a brace that didn't result in progression, that's good, because what the surgeons do is that they'll look to see the degree of scoliosis, and they'll only do that rod insertion when it reaches a certain degree.
Thank you. Before we're at the 20 minutes left, because we don't want to keep you all night. We have questions left about sleep and breathing. Just to let you know, we'll do this fairly quickly. How do you avoid a Rett girl waking up in the middle of the night is the way this question's worded. So what are some things we can do to improve a good night's sleep? Anybody want to jump? I don't think I think I have Dr. Carter written down here, but anybody can jump in.
Yeah, I mean, I can say a few things. Sleep is a huge topic, and like we could talk all night about sleep. So I'm struggling a little to know where to start. I see some questions in the sidebar too about medications. I think before I talk about medications, we need to back up the train, because sleep problems in children are common. And people are common, right? And some of the things that work for typical children and typical people will work for your child too. And so I would encourage you to read up on behavioral strategies and common sense things like, is she getting caffeine or sugar too close to bedtime? Is she napping too long in the day or falling asleep at school? Are you putting her to bed too early? Are you going into her room when she makes noise and rewarding her with your attention? And so like there are a lot of somewhat simple things that you can do, but I think the first sort of step is to make sure that the sleep problem is not due to a medical issue that should be treated. For example, reflux, seizures, sleep apnea, and your doctor can help you figure that out by sometimes just by asking you questions, and sometimes by doing tests. But assuming that your child is healthy and those problems have been addressed, if they're there, they can still have sleep problems. And I guess waking up at night is a real problem for a lot of families. And if it's occasional, then it's maybe not a huge problem. But if it's many times a week, many times a night, for many months, obviously that is not a sustainable situation for any family or child. So, so you might want to talk to your doctor about medications, and if you tried everything else. And some of the common ones are, so melatonin, which is actually better for sleep onset and doesn't really keep you asleep all night usually, so it's not usually as useful for keeping you asleep, but relatively safe. And then there's a lot of different medications that could be tried if you're really at the end of your rope. So some are trazodone. I know a lot of people in the States are using that. Clonidine. Some people have mentioned various sort of heavy sedatives, like somebody's mentioning, I think, Seroquel. Somebody else mentioned something else. Anyway, so there are a lot of potential options there that you could talk through with your doctor. Yeah, I think I'll let someone else add on to that. Maybe.
Yeah, most of the questions here are about medications, and I think in general that might be a response about how to talk to your doctor about that might be what we're getting at.
One thing we do know is that the levels of melatonin are low, and that's been measured. One of the first studies was what we did here. And in fact, not only are they low, but they don't ever get to the normal range that we normally that we would see. So the introduction of melatonin, especially in children that are having sleep difficulties, earlier you started, and you don't give it to them at 9 o'clock in the night and expect them to sleep right away. It has to be given earlier on. And that's where the problems arise, is what we know. You can measure it if you want to, but on the other hand, we are aware that the secretions of melatonin are low in the majority of the children. So it can be used before you use something else.
I would just add, and as far as the medication question goes, I think Dr. Carter, hit the nail on the head that we kind of, we as your physicians, I hope, recognize that it is not a sustainable situation for people to kind of go on and on and on and on with sleepless nights forever. It's not good for our patients with Rett syndrome, and it is not good for their care providers who we are trying to, help and support, and we don't want any of you to be getting burnt out. So hopefully, any of the, primary care even could become involved in this conversation, but certainly any of the specialists that you see regarding the Rett syndrome. There's lots of different medications that can be used for sleep. None of them are great, and none of them have really, significantly better evidence, one compared to the other. Most of them don't really have great evidence for sleep benefit, particularly in a population of people with developmental disability. And so really what it comes down to for me personally, and I'll let others speak for themselves, but often, if we've gotten to a point where we really think that we need a medication strategy, the behavioral strategies and other things have not been effective, then often we're looking at choosing a medication based on sort of its side effect profile and trying to see if there's something that might be helpful for us in another way. So, like if there are also concerns about low mood, then we might be looking at using an antidepressant medication that also has sedating side effects. If there are also concerns about pain, then we might be looking at using pain type medication that also has sedating side effects. So it really does come down to trying to choose something that sort of makes sense with the constellation of symptoms that we're seeing in an individual person.
And of course, the other important thing is to, in the history, is to be sure that the child is not refluxing or doesn't have any other medical issues that's keeping them awake, because often we kind of focus on sleep, but forget that there might be other reasons why the child may not be sleeping. So I think that the history is really important as to what parents say.
Dr. Budden, since you had said that children with Rett syndrome have low melatonin levels,
Yes.
And the question I think that one of the parents was asking is that the child gets to sleep but wakes in the middle of the night. Are there any sustained release melatonin available so that there would be melatonin not just acting immediately but later?
Well, currently, I'm not sure there's any sustained melatonin available. There might be, but I'm not familiar with it. I do recognize what you're saying, and the question then comes up is whether we need to give them a little bit more or not. And that is a very difficult issue to try to work through, because they'll go to sleep, but then they might keep waking up at night. And if they do wake up at night, then the other question, which I was just saying, is are there other added medical issues or problems with reflux or wetting themselves or whatever? So we have to look at that, but I'm not sure that there is one that has sustained release. And if somebody knows, you might have better knowledge about that than I do.
I recall the sleep clinic at Sick Kids saying that there was a sustained release form that was available. I'm not sure how effective it is for preventing kids from waking up, but I remember them saying there was one. I don't know where or how much it is or anything like that.
Well, I'll look it up and send Karen the information. How about that?
I agree with Dr. Carter. I remember a couple of details. Some families would say that they buy it at Costco and that it comes under a brand Super Sleep.
Oh, okay.
Is that the one with the tryptophan in it? Maybe I remember. I think it was in the Angelman syndrome clinic actually that one of the parents showed us the bottle and it had tryptophan in it, and they said that it really helped for a child with a related similar condition.
Yeah, I think you're right. Yes.
Cool.
Well, thank you.
Okay, we're going to move on, just in the interest of time, to the breathing question. And then I am putting in the chat the contact information for Kevin Morton, because we'd like your feedback on what you think of these kinds of forums. We've had, I think this might be our fourth now, considering we couldn't have a live conference. And any feedback you have or more questions. I know we didn't get to all your questions. I know that Kevin was going to address the question about clinical trials. So maybe that person can contact him by email, because there's a whole recording from 2 weeks ago on clinical trials. So we will get to the question of breathing, and I don't have anybody's name beside it. So first come, first serve. I randomly noticed bluish lips and nails along with shallow breathing. What could be done about that?
I thought a bit about this one. So I actually don't think that's a breathing question. I think that the breathing observation is probably coincidental to the bluish extremities and lips. So it's very common to see just bluish or reddish hands, feet, and sometimes lips, and that's called peripheral cyanosis. And it's not due to anything to do with the breathing. It's due to constriction of the tiny blood vessels in those organs. And so what you're seeing, what you're seeing is the blood that is there. It's not getting the oxygenated blood. It's only getting the deoxygenated blood. And so I think that that's really not related to breathing so much. Of course, if you stopped breathing, you would turn blue, but that's a different situation. And if your children's extremities turn blue and red, it doesn't mean she's not getting enough oxygen to her brain, and it does not mean so if she passes out, that's a different story. But if she's otherwise happy and herself and warm, like she's not too cold, it's really nothing to worry about, and really nothing you can really do about it. It's a Rett syndrome phenomenon that has to do with this autonomic nervous system dysregulation. I think that's my sort of take on it.
Anybody else?
Well, we've, the first time we started noticing this was when we first started seeing those children. And I remember the dentist running down the corridor calling me saying, the kid is smiling and laughing, but her oxygen saturation was 68 and he didn't know what to do. And course, at the time we knew very little about Rett syndrome, but if you measure all the children, a lot of the times the oxygen saturation is running on the lower end rather than normal. And this was actually also being measured in Sweden. And I remember a lot of the children they did not have adequate oxygen saturation. So what you're talking about is absolutely right. You know, the blue, cold feet, hands, and that's all an autonomic problem, really. So sometimes you don't have to worry about it, but some people do. And there's, I don't think giving them oxygen at the time is particularly useful because they're smiling and laughing and walking around,
I have a follow-up question. This is just out of curiosity. So in addition to the sometimes blue extremities, if we take our daughter swimming in a pool that's not super warm, she can only stay in for 5 or 10 minutes before she starts to turn the purple. And then we just take her out. So it's clearly related to the cold temperature. Is that a similar issue, or is that just they can't regulate their body temperature?
Well, all I can say is they cannot, because we see a lot of that in kids who really kind of get really cold and blue very quickly in the swimming pool. Yeah.
Okay.
Yeah, I think it's, sorry, were you going to talk, Vicki? Oh, somebody just said, we have the same cold pool problem. In terms of the autonomic problems, I guess when you said it was breathing, I guess I should qualify that the breathing issues are autonomic problems also. So they're all sort of the same kind of family. So it's, and I think there was a question about hyperventilation in there, was there?
Well, I don't see it, but I think that is a common question. So maybe that can be our last issue today, is anything to do with breathing. There's hyperventilation, there's breath holding too, right?
Yeah, I mean, there's all sorts of funny breathing patterns, and they can really scare parents when they don't know what's going on, and they can really scare doctors when they don't know what's going on, because we're trained, as doctors, we're trained to measure your respiratory rate, and if it's high, there's a problem, right? Or if it's low, there's a problem. And so I think maybe the other more experienced doctors who've seen kids over and over for many, many years have, in my experience, would say that the breathing problems are not really big problems in terms of the big picture of what else is going on. Like it can be unsettling looking, but once you get used to it, you realize that it's not really harming them so much. But I think there are some people who have noticed that the hyperventilation gets better with certain drugs. Like I think Dr. Sell mentioned Topamax being one that some people said, oh, you know what, we gave her Topamax for her seizures and her hyperventilation went away. And so I think that's been reported a few times. So not that I would give a medication for the hyperventilation necessarily, but that's something that's been shown, I think.
Anybody else want to add about breathing? We're going to wrap up in a minute. There's a question about body temperatures. Do our girls have prolonged fevers because of the difficulty regulating temperatures, or is fever a separate thing?
I don't think that they have prolonged fevers. I don't know about the rest of you. I've not heard that. I think it's a separate thing. It has to do with inflammation and the body's reaction.
Jennifer, I gave you my non-doctor answer there. Sorry, I'm a little overtired. We're going to wrap it up, though. If you have more questions, send them to Kevin, because he knows everything. I put Kevin's email address in the chat. He did want us to let you know that ORSA is actively working on a lot of different angles for more clinical trials. To get back to that other question. And I think Kevin can tell you more about that if you want to email him. there's a lot of things where they can't tell you publicly until they've signed all of these non-disclosure agreements. But if you find the recording from a couple weeks ago, Brian has put that on Facebook. There's lots of information about, especially the one that's going to happen soon in Toronto, which is great. So I just want to take this opportunity to thank all of you who came and spent 2 hours with us, came onto the computer at least, and we gave you a lot of really big topics to cover in a short time. So thank you for being game to do that. We appreciate you. Thanks very much. Everybody's free to go. If you have more things to say, you can put it in the chat. Brian and I will stay here for a minute.
Well, thank you so much. Yeah.
Thank you.
Thank you for having us.
Thank you.
Thank you.